All right, can everyone hear me okay? Is that all right? All right, well thanks again for having me here today. I'm really excited to be here today on what's a really nice day. So I'm going to go through today just some common causes of knee pain, some of the things that I do as an orthopedic surgeon to help patients out with knee pain, and maybe some tips and tricks to avoid seeing me altogether. Like Ron said, so I'll go through a disclaimer. Things that I specialize, so it's specifically in sports medicine, but what I end up treating most are knee and shoulder injuries. And I run the gamut from weekend warriors, young athletes, up to doing joint replacement, as well as fracture and trauma surgery. So, but today we're just going to focus on knee problems. I'm going to go through, again, probably the most common causes of knee pain that I see in the office, our most common treatments, go through some of the newer and exciting things that we're doing in the office, and then at the end there'll be time for questions. So we'll get started. So and there's a host of things that brings people in to see me for their knees, but overwhelmingly the most common ones, the ones I see all the time, is probably off of this list here. So arthritis, or what you think of as wear and tear, high mileage on the knee. That's probably the #1 reason we see people in the office. But also things like tears of the meniscus, ligament injuries, kneecap problems or runner's knee, and tendonitis. So we're going to go through some of those today. But first I'm going to go through just a quick overview of what the knee is made up of, and so sort of the mechanics of it. And as an orthopedic surgeon, they sometimes think of us as a glorified mechanic or a carpenter, but very much the anatomy is critical. The way the human body is made is really amazing, and a lot of what we're trying to do is recreate that with injury and get you back to sort of the mechanics that really work well. So the anatomy of the knee, we have 3 bones that make up the knee joint, 2 tendons, 4 ligaments, and then 2 different types of cartilage. So looking at the bones that make up the knee joint, we have the thigh bone or the femur right up here, the tibia or the shin bone, and the patella, or what we call the kneecap, which rides right in the middle. And then you have 2 really strong tendons around the knee joint. And there's a difference between ligaments and tendons are at the end of a muscle that attaches to a bone, and ligament is something that attaches 2 bones together. So the 2 big tendons around our knees are quadricep tendon, and so that attaches to the top of our kneecap right there, right from our quadricep muscle, as well as the patellar tendon. So this goes from the underside of the kneecap down to the tibia or shin bone. We have 4 ligaments that hold the knee together, and very often I describe this as sort of ropes that hold your knee together. So we have the collateral ligaments on the outside of the knee, what we consider and you can sort of make it out here, the medial collateral ligament and the lateral collateral ligament are on the outside of your knee. And then we have 2 cruciate ligaments in the center of the knee, we call the ACL and the PCL, so the anterior cruciate ligaments. And those really give us the stability about the knee joint. So it's these 4 ropes that hold us together. Then we also have 2 different types of cartilage inside the knee. So the first type of cartilage we call articular cartilage. So this is sort of the end of the bone, and we think of it as a cushion, or we always describe it as a tread on a tire. And this is very often when you get wear and tear, this is what we lose on the end of the bone. We lose this cushion. And the articular cartilage is a special type of cartilage called hyaline cartilage, and it's really amazing. It's very resilient, and the amount of glide that you have on it is really incredible. Almost hard for us to recreate, even in our bioengineering labs. Just how slick the surface is. But when you look at the end of the bone, this is a picture from surgery actually of a scope inside the knee. And you see this nice smooth white surface, and that's really pristine articular cartilage right there. And this is the starts of arthritis, and this is what it starts to look like, almost like a pothole. You start to get wear and tear, and that's what the starts of arthritis look like there. And I'll often describe, we'll often describe, if you imagine that what articular cartilage is if if you imagine the end of a chicken bone, that really white, resilient, that's on the end of the chicken bone, that's what articular cartilage is. That's what the cushion is. And so when we talk about arthritis, it's really the loss of that cushion. And then there's another type of cartilage in our knee we call the meniscal cartilage. And this is actually made of a different type of cartilage called fibrocartilage. It's maybe a little bit tougher. And they're actually two U-shaped cushions. And you can see here a medial meniscus and a lateral meniscus. And these can get damaged as well inside the knee, but it's a little bit different. And you know, sometimes it's confusing in that we talk about a cartilage injury, and we have two different types of cartilage. So this isn't necessarily tears in the meniscus, exactly what we're describing for arthritis, but it's, you know, in these little U-shaped shock absorbers is what we think of them as. So those are really the components of the knee. So now just briefly going through sort of some of the major injuries or causes of pain. The first that I'll talk about is ligament injuries, and this is more of an acute injury, and as a sports medicine doctor I see this all the time. You know, I'm out on the sideline in the football games. So these are the big traumatic injuries, and this is something that is not subtle. You know, and it doesn't gradually build up over time. Someone knows that they've had a ligament injury. So it's can be from a big trip fall, car accident, again, you know, a big lineman sweeping into your leg. But you know, things that oftentimes people will have felt a pop or something, you know, they can feel something significant has shifted inside the knee. And this is involving one of those four ropes that I described. So the collateral ligaments is usually one of the injuries. There significant swelling, most people difficulty bearing weight on it right afterwards, and again, not a subtle injury. And the problem with these leads to instability. So in younger people who sustain ligament injuries, you know, the worry is down the road. It's that when what I describe as instability is you know, looseness in the knee. So if it's not moving in a nice, you know, conformed way, that looseness can over time beat up other things in the joint, and then that leads to arthritis down the road. And that's what we worry about, you know, in sort of treating these and stabilizing the knee when they're younger. The treatment of the ligament injuries is unique in that the outside ligament injury, so the medial collateral and lateral collateral ligament, actually live outside of the knee joint itself. And the knee joint is sort of bathed in synovial fluid. It's this rich fluid that allows the knee to move nice and smooth. But there's very little blood supply inside the knee joint itself. Outside the knee, around the medial collateral and lateral collateral ligaments, very well vascularized, meaning lots of blood, and that's how we heal. And so these injuries, even, you know, complete tears of the medial collateral ligament, which is probably what's happening right here. So, you know, it's a fall here, that inside ligament gets stretched and torn. Great capacity to heal itself, and oftentimes they're just being treated in a brace and the body can heal itself. The anterior cruciate ligament and the posterior cruciate ligament inside of the knee, so it's in the middle of the knee, different story. Those will not heal themselves, and a lot of it has to do with the access to the blood supply, because there's very little blood supply around the anterior cruciate ligament, and so we see that, you know, it lacks the ability to heal itself. And these are the ones that we're typically operating on and typically require surgery. So, and just briefly on probably what you hear the most about as far as ligament injuries is ACL tears. It's one of the most common things that we treat as far as major ligament injuries inside the knee. And it's, you know, from a twisting injury. It's very, very common in our athletes. You know, this is a good picture of what the ligaments look like crossing up. So the posterior cruciate ligament, the anterior cruciate ligament, and again, once it tears, it just lacks the ability to heal itself. And the problem with this is, you know, and you can live life without an ACL, you know, because even walking straight ahead and things like that, you don't necessarily need it. You need it for planning, pivoting, so, you know, more aggressive, you know, athletic pursuits. But when someone has an unstable knee and pushes it, then we see, you know, it continues to beat the knee up, and then we worry about arthritis down the road. So, you know, not only in getting back to sport, but we worry about stabilizing the knee to help save that knee in the future. And, you know, I do a lot of ACL reconstruction, and this is something, the surgery, you know, it's not that we can't really repair it, so we're reconstructing it with a new graft. Very, very successful surgery in restoring stability, getting people back to sport. But probably even more important than that is getting a nice stable knee to prevent arthritis down the road. So 15, 20 years down the road, we know that people without an ACL have a much higher risk of having a degenerative knee or a degenerative joint. So Next thing I'm going to talk about, and probably more common than ligament injuries, is meniscal tears. And so this is one of the most common reasons that I see knee pain in my clinic, is tears of that meniscal cartilage. And again, we talk about the two different types of cartilage. These meniscus are these little shock absorbers that live inside your knee. And you know, they can be torn from a traumatic injury, meaning like a trip fall. Very often we see it from something innocuous though, but the meniscus can get loaded when you're standing and twisting. And that's very often when people will feel, you know, maybe some pain from a meniscus, tears in the meniscus, is a twisting injury or getting up from a squatted position. So when you're squatting or kneeling down, it can really load these cushions, and that's oftentimes when people can feel it. Sometimes the meniscus can tear it over just repetitive use, and so something that, you know, a lot of times patients come to me without really knowing, you know, that, you know, I didn't have a trip or fall. I'm not really quite sure what I did, but this is a new type of pain. And the pain in the knee from a meniscus versus what you get from arthritis is sometimes difficult to tease out. But some of the mainstays that we look at is meniscal injuries, these tears in the cartilage, are very mechanical. So the problem with a meniscus tear has to do with this moving about in the knee. And once again, you know, healing in the human body has everything to do with blood supply. And these meniscus pads actually have a fairly poor blood supply. You know, around the outside they have a little bit of blood, so you know, they may have the capacity to heal out there. But a tear like this, very little blood, and so we see that it lacks the capacity to heal itself. And little tears in the cartilage pads are something that you can live with. You know, and very often people get degenerative tears of their meniscus, so maybe little injuries that build up over time that don't affect your knee. And you know, if you're not feeling it, this is different than a ligament injury that we leave it alone. So if you have no symptoms from it, we leave it alone. And there's a lot of good studies that show us that if we look at, you know, MRI of asymptomatic people, especially as we get older, so common to have meniscal tears that you don't even know about. So sometimes we're cautious about that when we order MRIs, is that you're going to see something that you know, may have been there for a long period of time. But the things that people will tell me, so when a meniscus is giving you problems, we think about mechanical symptoms. So people will describe catching or locking, or something doesn't feel right in the knee, and very often they'll point right at it. And that's what we call like sided pain. And so, and this is very different than arthritis. You know, someone with an arthritic knee, I'll ask them, well, where does it hurt? And it's difficult to describe. They'll just, you know, I don't like it. It's all, you know, they can't. But people with a meniscal injury, they'll point right at it, like right there. Doesn't feel right. Something's moving around. You know, especially when I squat, when I load it, it doesn't feel good. And you know, then on examination, there's certain things. This is sort of the classic test that we do. It's called the McMurray's test. And so I load the joint and then twist it, and it's that sort of that twisting action that agitates it. And where people get problems with meniscal tears has to do with, again, mechanically irritating the knee. And it can behave sort of like a pebble in your shoe, meaning that it can be a small little tear, but as it flips about, there's a lot of load that goes through the knee, and that little tear can actually really agitate the knee and just keep it irritated. So what we do investigating this, so you know, the physical exam, the history is very important for me. I'm looking for those things, you know, sort of the mechanical signs. You know, someone will tell me when it started. We see swelling as a very common sign. And then we'll almost, you know, as an orthopedist, I almost always start with x-ray. So x-ray is so important for this to, number one, see how much arthritis is in the knee. Because if someone has a very, you know, if you already have a lot of wear and tear of the other type of cartilage, or you're sort of losing tread, real common to have meniscal tears along with that. And so that doesn't necessarily mean, so then I wouldn't necessarily, you have to look at, you know, just treating the meniscus may not be as fruitful, or you may have to address the arthritis more. But particularly if the x-ray then looks good and you say, oh, you still have a good amount of cushion in the knee, you still have a, you know, no significant arthritis, but yet you have all this pain, then I'm thinking much more that the meniscus could be driving almost all these symptoms. And you know, oftentimes, you know, how we see the meniscus is on an MRI, because the x-ray shows us the bones very well, but it doesn't show us the soft tissues. And the MRI shows us the soft tissues and, you know, the ligaments, these meniscal pads. And usually, I don't rush to get an MRI if it's, more subtle symptoms. And oftentimes, there's many meniscal injuries, small tears, that get better after, say, 3 or 4 weeks. But after 3 or 4 weeks, if you remain symptomatic with a meniscal injury or meniscal symptoms, the chance of it going away becomes a lot less likely. Because again, it's not necessarily healing itself. And it's really sort of declaring, is this going to be a mechanical irritant in your knee? Like, is it going to be unstable and moving about? Because just to have a tear, I wouldn't rush after treating that. So very often, I think, with, knee pains, obviously the rest, ice, elevate, give it some time to, declare itself. But after, say, the symptoms stay persistent 3, 4 weeks, hey, it's not getting better, then that's when we would pursue getting an MRI. And this is, if you imagine, you're looking at the side of the knee on an MRI here. So this is your leg bone or your femur. That's your tibia. This would be the front of the knee and the back. This is that meniscal pad in the middle. And the front part of the pad looks very normal right there. And that's what a meniscal tear looks like on MRI. So a tear right through that cartilage pad. And this very much can agitate the knee and flip about. So, and when the symptoms remain for a few weeks, it can be very well treated with arthroscopy. So, which is a simple procedure with a scope, minimally invasive. And arthroscopy was, initially designed just really as a diagnostic procedure. 20 or 30 years ago, just putting it in, really looking inside the knee to give us an idea of what we would do for an open surgery. But really, it's been one of the major advancements in orthopedics, is what we can do with an arthroscope now is really amazing. I mean, it almost seems limitless what we're able to do now inside the joint with an arthroscope. So, our techniques and a lot of the things that we're using allow us to do some amazing things. So inside, this is a picture of at surgery, so arthroscopy. This is inside of a normal knee. So this is the medial meniscus right here, and that looks really nice. That's a nice cushion, beautiful looking knee right there. So nice cartilage. This is what a meniscal tear will look like. And so you see how this is, torn through here. This is flipped out in, and this is what can agitate. And that's what people feel the pain from, a meniscal tear. And so the treatment with the arthroscopy typically is what we call a partial meniscectomy. So this is a good example of a patient who has unstable tear there, and again, if you imagine, there's very little blood in this tissue right here, so this will not heal itself. And this is simply what we call like a trimming procedure. So this is sort of a before and after. So smoothing that out, trying to take sort of as little meniscus as possible, because it serves a purpose. It's a great shock absorber, and without our meniscus, we have higher rates of arthritis down the road. And these treatments are a little bit different than what we were doing 20 or 30 years ago. So there used to be, with a meniscal tear, we typically, they would go in, it used to be a big open procedure, take the entire meniscus out, and patients would feel great, because they don't have that mechanical irritant anymore. But with losing the meniscus, it really accelerates the arthritis because of, that you lose that cushion. So we do everything we can to preserve as much as possible. So, I'm leaving as much meniscus as I can here. And we're in certain tears, we're able to do meniscal repair as well. However, it's tricky because it has to be a certain type of tear where there's blood close by, and it has to be sort of like a nice clean tear. So it's very rare. Maybe far less than 5% of meniscal tears are able to be repaired. So the vast majority we're sort of trimming up or smoothing out. And this is an example of what a meniscal repair might look like. So at surgery, we have I can put a suture through there, and this tear, it looks much different than the last in that it's right on the back side of it. It has the ability to heal itself. Again, a little bit more rare, but we're making a lot of advancements as far as what we can do for repair. So now I'll talk a little bit, so probably far and away the most common reason that people come to me is osteoarthritis or arthritis in the knee. And arthritis is defined as inflammation and pain in the joint, and knee arthritis can really affect people in a dramatic way, meaning limiting your just simple activities of life, walking, going up and down stairs. And it's really amazing the amount of lost work time and the significant disability that knee arthritis causes in this country. And the most common causes for knee arthritis are what we call osteoarthritis, which is sort of like wear and tear. You call like, you know, a high mileage knee, as well as rheumatoid arthritis. Those are probably the two most common, but there's over 100 different causes for arthritis in the knee. And it can be from, you know, old trauma, you know, it can be from other, you know, activities in the body, it can be from infection. So there's a host of reasons that you can come to have an arthritic knee. The most common symptoms we'll see is pain with weight bearing. And it usually builds up over time, and that's a little bit different. Like I was describing patients, you know, with maybe a more mechanical problem in their knee. This is just sort of a global losing the tread. So you're losing that cushion. So it's, you know, problems with weight bearing, standing on my knee, achy pains. We see very often arthritis leads to stiffness. So I see patients come, they start to lose range of motion, especially in extension. So the knee starts to get a little bit tight. So, and you know, grinding and things like that. So those are the most common symptoms that we'll see. And in making the diagnosis, I'm looking for, you know, not only a physical examination, but, you know, some of the story, trying to delineate how long it's been. X-ray, again, is a critical part of making the diagnosis for arthritis. And we're looking, when we look on X-ray, this is two examples. So this is a very nice, healthy looking knee. And on X-ray, I'm looking for that space in between the bone, because what's clear on X-ray is our articular cartilage. So again, it doesn't show up on X-ray. So this example over here shows us a nice, clean, you know, joint space here, good cushion. So that's really essentially no arthritis in that knee, as opposed to what we call bone-on-bone arthritis. And that's as this is, you know, crushes down. And this looks like not a happy situation, you know. And the articular cartilage is sort of amazing. It has no nerve endings in it. So there's very little, you know, when articular cartilage is rubbing against like more articular cartilage, there's essentially no feeling in that. And so it generates no pain. Our bones have a lot of nerve endings in them. So as you wear away and you start getting that bone rubbing on bone, it can be terrifically painful. And that has to do with just how innervated it is, so the nerves in there. And that's what, you know, as we start to develop the pain of arthritis. So how do we treat it? You know, overwhelmingly, we see, you know, living with arthritis, when we study this in a very robust way, which we've been looking at, you know, we've had great studies on this. Overwhelmingly, the two most important things in living with arthritis are shown to be over and over again. It's non-impact strengthening as well as weight loss. So and non-impact strengthening has to do with activity. So the stronger the muscles are about the knee, they act as a shock absorber. So the stronger your muscles are, the less the bone is going to see stress. So we really encourage, and it's really, you know, I'm a big believer in sort of move it or lose it. And we see that activity is so important. And even, you know, like weight-bearing activities or being on the knee are important because they build up that strength. And so sometimes it can be counterintuitive because people, you know, get a lot of knee pain and they think, oh, I'm going to baby it. And that can actually be the worst thing that you can do, because then things degenerate and it can actually make the situation worse. And so there's some studies that show us that even light impact, you know, or moderate amounts of impact don't cause damage to the knee. And, you know, we look a lot at running, you know, so people wonder about, you know, whether running causes arthritis. And there's actually good studies that show that moderate amounts of running actually don't lead to arthritis. And so we think that there's a little portion of that load and almost like, you know, using the joint that helps keep the cartilage healthy. So again, I really encourage my patients to stay active. You know, things like physical therapy, strengthening activities, you know, things like in a pool, on a bicycle, rowing machine, elliptical, really, really important. And, you know, a lot of it is finding something that you enjoy doing, because if you don't enjoy it, you just won't stay with it. So, and there's so many different ways to get exercise. You know, and I wouldn't think of it. I always counsel my patients that, you know, some people just hate the thought of going into a gym. You know, they're like, oh, that's what exercise is. And there's so many different ways. I encourage you to just find activities that you like doing and stay active in that way. The other things we'll use, you know, oral medications, injections, you know, sometimes bracing, you know, sometimes a brief period of using a cane walker to unload the knee joint. So with the over-the-counter medications that we typically recommend, you know, the first line typically is anti-inflammatories or non-steroidal anti-inflammatories, such like ibuprofen, Motrin, Aleve. And this is really, you know, a lot of times the first line that we're doing for arthritis or an inflamed joint, because they can be really effective for inflammation. There are side effects that come with it. So, like any medication, a short course, I think the side effects are very low for anti-inflammatories, but there's concerns, with heart conditions, it's processed through your kidneys. So to live on anti-inflammatories, comes with some side effects. But for, an acute flare of arthritis, I think it's very, very helpful, rest, ice, take some time to let the knee calm down. Because arthritis is funny in that, as it's a chronic condition, the pain associated with it can be very temporary sometimes, meaning you have peaks and valleys, like kind of a flare of arthritis. And if you can calm that down, and sometimes the earlier you can calm that down, it can recover, and then the pain can get better. The other things that we see that can be effective for arthritis, there's a lot more emerging evidence around omega-3 oils. So what's in fish oil, that it may be involved in the health of articular cartilage. And it's not a cure-all. We know that it won't grow cartilage back necessarily, but there's good evidence about that, and I've seen it help my patients a lot. So that's something that I usually would recommend, and either getting those omega-3 oils from a healthy diet versus using a supplement like fish oil. Another natural anti-inflammatory is turmeric, and I've had some patients who have success with this, and this has been used for quite like thousands of years as an anti-inflammatory, and again comes with a little less, it doesn't have the side effects, maybe not quite as potent as what like ibuprofen or Advil is, but things that I think are worthwhile in trying as a anti-inflammatory. Then let's say that doesn't work. There's knee injections that we very often use. So probably the number one injection that we do in the office is cortisone, or we call a steroid injection. And the it's the same thing. It's a sort of a family or a class of medication called a glucocorticoid, and so that's what we call a steroid or cortisone. And there's a few different types of cortisone that we would use, but it's really, they have the same effect in that it's a potent anti-inflammatory. And so it's very helpful to reduce the inflammation of an arthritic joint. But I wouldn't rush to get it. Like a day or two of pain, I usually wouldn't rush to get a steroid injection. But when the knee is really, really inflamed and irritated and hot, and it's not getting better, can be really effective in relieving that pain. And it doesn't change anything inside the joint, like it's not healing your joint, but it is turning off that sort of inflammatory cascade that's happening in there. And there are some thoughts about high-dose steroid. People worry about getting too many steroid injections, and that can damage tissue. And we see high-dose cortisone can weaken tissue, and we see that in many years past, athlete getting an injection once a week to stay on the field is no good, and that can weaken tissue. But the studies will show us that up to about 3 injections a year, cortisone injections into one joint, doesn't cause that damage. So usually most of us would say that, on about, you could get a cortisone injection, you'd be able to repeat that in about 3 months. And, and while this, theoretically in high doses can weaken tissue, there's also the thought in that turning off the inflammation in your knee can actually help preserve the knee. Because when you're having a flare of arthritis, the inflammatory cascade that develops inside your knee can actually be damaging to articular cartilage. So when our body gets really inflamed, there are these things that come to attack, what is bad, and that can sometimes attack our articular cartilage. So I think that in calming the knee down, we think that turning that cycle off, it can actually help preserve some of the cartilage. So I think that rather than suffer through, I think the cortisone is helpful in that way. We also use what we call lubricant injections, or viscosupplementation. And they call them rooster comb injections, and and that's from we initially developed it from a rooster's comb is a really great source of cartilage. It's actually just made entirely of cartilage. So we harvest it, or would harvest it from that. But it's basically, it's called hyaluronic acid, what we're getting. So it's a normal lubricant that lives inside the knee, and so it's nothing but healthy for the knee. And so it's different than cortisone in that way. in that it's sort of trying to stimulate, a healthier environment for your knee. And it's usually a series of 3 injections we put into the knee. And we've seen some good success with it, but again, it's not a cure-all. And the higher level studies that we do on it show us it's about 70% effective for mild to moderate arthritis. So people with severe arthritis, we see it's much less effective. So bone on bone, it's hard to say that that would give you many benefits. But mild or moderate arthritis, we see about 70% effective for taking care of the pain or taking pain away from walking and things like that. The other thing that we're really, is really exciting in the field of orthopedics right now is more biologic injections. And we're thinking, in the future of orthopedics probably centers around this. And a lot of us are excited about, in the future, looking at sort of having our body, heal these things rather than using plastic and metal. And that's 10, 20 years down the road. Unfortunately, it's not here right now. But the things they're looking at now is, intervening, in someone who's in their 20s, who everyone in their family has arthritis. And if there's ways to intervene then, biologically, you may prevent the arthritis at that point. Now we're still late to the game, so we're looking at what do we do biologically after the knee has already degenerated, because we really haven't found a way to grow that cartilage back. The two most common, the one that's the first one that we developed was called platelet-rich plasma. So you hear about PRP injections. And I do these fairly frequently, and I use it. We use it all the time in athletics, and you hear in pro sports we're using it all the time. For my athletes, for especially soft tissue injuries like hamstring strains and things like that, really effective. And what it does is maybe accelerate the healing process. So an athlete who has a hamstring tear that might take 6 weeks to heal, we see with PRP it can reliably maybe heal in 3 weeks and then back faster onto the field. But we've also seen some application with arthritis. And they actually use it a little bit more commonly in Europe, but they'll use it in a way similar to how we use the hyaluronic acid or the supplements, and that a series of 3 injections has been shown to be almost as effective, and in some studies even more than the lubricant injections. And the thought is that we're sort of taking your own blood. We have a special centrifuge that sort of concentrates the plasma, and specifically what we think we're getting is the platelets. And what's associated with the platelets in our blood is what we call platelet-derived growth factor. So it's a growth factor that's involved in healing, and it can help with inflammation. And so we're basically concentrating it, putting it back into an area of injury or arthritis, and we see that it's helped. The other one we're seeing more of is stem cell therapy, and it's really popular in the news. I'm sure you've heard quite a bit about it. It's we take it from your own body. Usually it's from the bone marrow. Most often we'll get it from the iliac crest, which is a great source of bone marrow, and spin it down and sort of trying to get these what we consider stem cells, like a pluripotent cell is what we call it. So maybe a cell that would be able to turn into tendon or turn into cartilage. And right now, we're not there as far as what we're getting is not sort of growing cartilage back. It might provide an anti-inflammatory effect, but so far the studies are showing us it's about equivalent to PRP. So these things are really exciting in the future for us, and probably what we're going to look to more in the future, but have some application now. So when all these things fail, then you look at, then you look at the surgical option. So when it becomes some sort of unlivable and these things aren't helping, we look at, the things we think about arthroscopy and, obviously knee replacement. So knee arthroscopy for arthritis, it used to be more popular, sort of clean out the knee, sort of clean out the bad humor was the thought. And that really has fallen out of favor. And there's good studies that show us that the lasting effect of that is not good, especially with advanced arthritis. So usually with someone who's having more advanced arthritis, like a cleanup procedure, going in with an arthroscope and just cleaning up the arthritis is not very effective. So those things I sort of would lean my patients away from, trying to make it livable with again exercise, weight loss. And Then when those things fail, thinking about knee replacement surgery. You know, when is it right for you? And a lot of, you know, the way I counsel my patients is that the x-rays tell a very small part of the story, honestly. You know, it might be like 5 or 10% of the story. So you have to have degeneration on your x-ray. Like the x-ray, you know, to prove you have arthritis. But there's some people who have terrible looking x-rays and live their whole life that way, you know, and say, and maybe mild pains, get occasional injection. And inevitably when we see those people, they're generally active and they don't carry a lot of extra weight. But then we see arthritis can affect other people and not even have nearly the signs on x-ray, but it can be debilitating. The pain can be severe and they've done everything. And so how it affects people is very different. And some of that has to do with our pain system and how people experience pain. But very much the most important part, more important than the x-rays, is how it affects you, how it affects your quality of life. And really, once it starts to pervade your life, you know, when I'm not sleeping well at night, I'm not enjoying the things I want to do, you know, I can't go here because of my knee. The knee is always on your mind. That's the people who are most happy to go through knee replacement. Those are the people who come into the office and give me a big hug and are so happy they went through it. You know, when you have little, like, smaller symptoms, it's not, you know, necessarily like a quick, easy surgery. You know, I have little aches, pains. You know, those are the people who aren't quite as happy going through the surgery. So, you know, and the vast majority of people who go through it probably say they've waited too long going to it. But again, I would tell you that you don't want to just rush into it. So, and what knee replacement is less of sort of removing the old knee and putting in a new robotic knee. It's not like a complete total overhaul, but more of like what we think of as a resurfacing procedure. So the problem is the ends of the bone are rubbing here. And so what we're trying to do is sort of get you a new lining surface here. So joint replacement, you know, we go in and sort of make skim cuts on the end of the bone here and place a new lining on the end of the bone, and everything else stays in there. You know, it's you know, the ligaments, the muscles, and those things. And what's in here is a really ultra dense plastic tray, as well as cobalt chrome. So it's a metal on plastic, and that's what the new articulation is. And again, takes away that bone rubbing on bone. This is a picture from an operation that gives you an idea of, you know, the cap on the end of the bone there. And in general, the surgical procedure, you know, we do it with typically like regional anesthesia versus general anesthesia. So it's something that you're asleep for completely, so you don't feel any of it. You know, we're making more minimal incisions now, so minimal midline incision. We prepare that bone, sort of like I said, sort of skim cuts, and, you know, attaching this the prosthesis to the end of the bone, and then closing it up. And, you know, a lot of us are doing more like, you know, suture skin closure versus staple skin closure. This is an idea of what an x-ray would look like, so sort of the before and then the after. And so you have, you know, no more, so a nice cushion in here. And what you don't see, what's clear on x-ray, is the plastic. So that plastic tray or cushion is what you don't see, and that's the new cushion that you have on the knee. Risks, you know, obviously with any surgery, so, you know, and the risks are fairly low with joint replacement, but it is, you know, something we worry about. You know, infection is a risk, and that's about 1% risk, and we're very hyper attuned to it. You know, we work in space suits and are just really, really meticulous about exposure to bacteria. But again, there's risk with any surgery. But we've seen the outcomes of this have been great, and we've done a lot over the last really 10 to 15 years, and the changes have been more on the rehabilitation side or what's around it rather than the prosthesis, because the prosthesis is still, or the capping that we're using is still very similar. You know, we've made some advancements. The plastic is a lot more dense or durable. But that hasn't changed as much as what's around the surgery. We're a lot more aggressive in getting people up out of bed, moving right away, and we've seen great success with that as far as, you know, people getting out of the hospital a lot sooner, getting back to life a lot sooner. We're also, and to the point where, you know, some of it we're doing on an outpatient basis. You know, at Coordinated Health, you know, we're doing probably, you know, more outpatient knee surgery than anybody in the area, and it's not necessarily for everyone. You have to have certain qualifications, but getting up, moving, and we see great success with that. And in general, you know, it is some recovery though. So people are on a cane or a walker for, you know, the first 3 to 4 weeks. The initial recovery is about 3 months. And then it continues to mature for even up to the first year. But people are generally very active by about 3 months, and we see great success with this surgery. You know, it's you know, back to activities. I mean, things you can even run with a joint replacement. You know, we kind of recommend lower impact activities, but very successful surgery. And that's, again, you know, sort of when everything else has failed. But really important as far as overall health, like getting back to an active, healthy lifestyle. Because once it really starts limiting you from being an active, engaged, healthy person, it, you know, not only affects your body, but it can affect your mindset. And I think that's why I encourage people just to stay as active as possible.